It's the Royal College of Physicians annual conference. Stay tuned for news, views and plenty of conference coverage. Welcome to Manchester. It's day 2 of our conference news programme, and once more we'll be bringing you insights on the important issues facing physicians in the UK and speaking to some of the key conference speakers. You can watch us on screens throughout the conference centre, in the plenary hall between speakers, in rooms at the Hilton Deansgate and online. Let's see what we have for you coming up in the show today. In the studio, Professor Alan Boyd and Dr. Adrian Woolfson discuss medicine and the pharmaceutical industry. Professor David Haslam on NICE and maintaining quality. Carol Postlethwaite and Orod Osanlou from the Trainee Committee. And Suzie Bailey from NHS Improvement. From around the conference, we head to the Ultrasound at the front door session, talk to some physician associates, and head out to talk to delegates about what they've learned. And from around the country, we visit University Hospitals Coventry and Warwickshire NHS Trust, Health Education England East of England, Royal Blackburn Hospital, the Future Hospitals COPD programme in Manchester, Papworth Hospital and Health Education England North East. Well, joining me now is Professor Alan Boyd, who is President of the RCP's Faculty of Pharmaceutical Medicine, and also we have Dr. Adrian Woolfson, who is from Pfizer. Well, welcome to both of you.
You're welcome.
Now, we're talking about how the NHS can afford new drugs. What have you got to say about that?
Yes, drugs are expensive, definitely. But I think for the future, we have to think about how we can change that and get the NHS more involved. So at the moment, anything that's identified and sort of discovered with the NHS doesn't actually is soon sold out. What I think we need to think about is, could the NHS actually take those first initial steps in a drug development process and increase the knowledge, and then because that value will go up, they can then sell out, and clearly that would bring more money back to the NHS and feed the system. Well,
do you think that they could do that? They could invest in developing new drugs. Do they have the capacity to do that? Do you think that?
I think the NHS has got an incredible amount of talent and resources which are being underutilised, and that's both the minds of the individuals who are actually working in the NHS, but also the infrastructure for managing patients, to perform clinical trials, and then the anonymised data which they have, and all of those resources could be used to leverage their position within the healthcare sector to help them to generate revenues and to form the basis of interactions with the pharmaceutical industry and biotechs and so on.
And this is slightly uncharted waters, isn't it? Because there isn't really a country that's doing this well, do you think?
No, it's not done at all. I mean, clearly we use hospitals and patients to do clinical studies, but it's not done on this basis. I mean, we've got a population of 65 million here, all captured within the NHS, and that doesn't happen anywhere else in the world. So, yeah, I think we can do more with the NHS to bring, new medicines.
And also, we're talking about using philanthropists, using NGOs, using other partners. So what do you see as the future there, Adrian?
I think that we've got a fundamental issue, which is that in 50 years' time we can expect to see functional cures for a great many common diseases of global significance, and we really need to think ahead to the future and say, what can we do today to prepare for that? And I think the NHS has really not changed its paradigm of operation since its inception in 1948, and really it's probably time to rethink how various things are funded and to see whether there are more innovative ways of engaging some of the external partners like the pharmaceutical industry and the biotechs and other agencies, and to see whether you can sit down at a table and actually come up with a new structure that's mutually beneficial, preserves the independence and intellectual freedom of scientists within the NHS, but also helps them to take new medicines forward into the clinic faster and more efficiently, and to get some of the upside of that.
Are there any particular disease areas that you're thinking are ripe for this? I'm thinking, say, with Zika or Ebola, there are several pharmaceutical companies working together and NGOs to collect the data.
Yes.
So are you thinking of any disease areas?
Probably things like oncology will be vital, because there's a lot of cancer patients around. A lot of the cancers we haven't got these functional cures for yet, and so working closer together, we can do that. In fact, as part of it, getting a cancer patient into a clinical study actually saves the NHS money, because they're not having the cost of the therapies, but actually they're actually contributing to the future research and are getting treated though at the same time, and hopefully getting benefit.
And I think in principle Alan's right that it makes sense to begin in one disease area, but hopefully this type of approach should be disease area agnostic, so that once you've in a sense established the beachhead with, say, oncology, you can then broaden out this model to other disease areas and hopefully eventually encompass all disease areas and transform the model which the NHS uses to operate by.
So basically it becomes a template to then roll out across the...
Right. Well, Alan and Adrian, good luck with that, and thank you very much.
Thank you.
Thank you very much.
Let's hear from Health Education North East now and visit their School of Medicine.
The School of Medicine in the North East provides a wide range of opportunities for training, both in the GIM related specialties but also in smaller specialties such as rheumatology, clinical neurophysiology. We're very fortunate to be in a region that consistently gets very good feedback from the trainees and from the GMC NTS survey, and I think that's down to the fact that the trainers in the region are exceptionally engaged with training, and we're all very keen to develop training programmes that deliver what trainees need and want.
I think what we have are really enthusiastic supervisors and educational supervisors and consultant colleagues that genuinely support trainees as they move through the programme, such that they get good training and they're ready for consultant posts by the time they exit the programme. And hopefully many of them will stay in the North East because of that.
We have a very strong academic training programme, starting at foundation level and going all the way through to completion of training. As well as strong academic opportunities to go out of programme, we have very good conversion rates for trainees in academic training programmes who then move on to complete higher degrees.
We offer 2 protected 4-month slots for academic work during the 2 years of the foundation programme. We also offer a very trainee-centred approach. What's really important is the close working between Newcastle University, our local NHS trusts and Health Education England North East in delivering a very integrated clinical academic training experience for our trainees.
We have a very clear vision and support from our postgraduate dean, Professor Kumar, who feels that strong clinical leadership is the key to delivering the education that the trainees need. For the CMT trainees, we've worked in collaboration with the Royal College of Physicians Northern Office to provide a practical skills training course which addresses all the practical skills that they need to complete for their first year of training. We're leading the way in many areas across the region, including examples where training programmes have started new innovative ideas. Gastroenterology runs a sprint training programme for their new trainees. Respiratory has developed a passport to bronchoscopy, again for their new trainees. We are very proud of the fact that our geriatrics training programme has developed a Geriatrics for Juniors training day, which is attended by trainees from all over the UK.
One of the reasons I love geriatric medicine up in the North East is that there's a lot of opportunity to do different things. So I've had loads of experience in old age psychiatry, in community psychiatry and community palliative care. I just think there's such a wide range of things that we can contribute to, and we've got a really up and coming system here that is interested in community geriatrics, which is obviously at the forefront of everyone's mind in the country at the moment.
Our cardiology training programme is one of the top ranking training programmes in cardiology in the UK. We have examples around the region in the Newcastle hospitals and the South Tees hospitals where they have dedicated cardiology and geography suites where they train the trainees. Simulation is taking an increasingly important role in medical education. As a region, we have a very strong basis of simulation training, with many of the different trusts having simulation suites.
Simulation facilities we've invested in because we know how useful they are to train. It's a very safe environment for people to train in. It's a very safe environment to make mistakes. And they're the realest that we can get before people meet patients. And we hope that that means that when they do meet patients, they're that bit better, that bit safer, that bit more confident.
We must also mention our Faculty of Patient Safety, which was set up in 2015 and has been recognised by the GMC as an area of good practice. This group brings together our human factors training, our simulation training, our technology enhanced learning, and how we learn from critical incidents across the region. The group pulls together experiences and knowledge, and uses all of the simulation facilities from the region to deliver excellent training events, establishing a great network of individuals who are keen always to work together. And we offer a great deal of training in all of these areas, which we think really enhances how our patients are cared for in the region.
Currently we have 3 educational training and leadership fellows who are currently working with us to develop training opportunities across the region, but also as part of their personal development they are developing their own skills in leadership.
There's a lot of talk about junior doctors and trainees being the leaders of tomorrow and having an important role to play in the future of the NHS. And this scheme really puts that into practice, so we're getting some experiential learning through spending time with chief executives, learning about leadership theory and also developing leadership skills during doing projects throughout the region. And I think sort of learning on the job or learning in practice is very important and a very effective way of learning leadership skills.
Often when people do train here, they stay in the region, and we have a number of training programme directors who've been here since core training, have trained all the way through and are now leading our training programmes.
I moved up here from Manchester, which was where I grew up, and I just fell in love with the region. The lifestyle up here is amazing. You have great cities, you have access to the countryside and the coast, but on top of that it's ranked as the best place to train in the country. And how do you beat that combination?
I think in addition to a really well structured programme, you're surrounded by great people, whether it's the nurses you're working with, your colleagues or the patients that you're looking after. I think this area is just a great place to work.
The best thing about training in the North East is how friendly and supportive it all is. There's a really good network of supervisors, clinical supervisors, educational supervisors and training programme directors to help you if you've got any problems, and everybody that you work with on a day-to-day basis is friendly and keen to help train you.
The North East is a fantastic place to live and work, but above that we're committed to providing excellent training facilities because we appreciate that we are nurturing and developing the trainees who are going to be our academic, clinical and educational leaders of the future.
This year's conference sees physicians get the opportunity to learn a bit more about an important skill for the modern-day physician. Let's take a look at what people are learning at Ultrasound by the Front Door.
The session's titled Ultrasound at the Front Door, and it's an introduction to bedside ultrasound for physicians. We've realised over the last few years that ultrasound can be very helpful at the first stages of someone's acute illness, and we use it more and more for things like people who are breathless, or people who have got kidney problems, or people who might need fluid draining in various places. And what we're teaching them here is basics about how to look at the chest on ultrasound, how to look at the kidneys and look for evidence of fluid in the tummy, to look for blood clots in the leg, and also to look at the heart and see how well that's working and how well that's pumping.
I've personally not ever had any experience with ultrasound as a medical student, as a foundation doctor, and it's obviously all around us. So I thought, get my hands on an ultrasound probe, have a look at, have a go at feeling around, see what it's like, and identifying some common structures, and really put things in perspective for me.
I'm coming towards the end of my specialist training, and I'm considering jobs that involve quite a lot of acute medicine, and I thought it would be quite useful to have experience of sort of front door hands-on ultrasound training.
There are 4 views we learned today. There is parastanal, long axis, short axis, and then also apical view and then subcostal view, which is quite good.
I work as an acute medical consultant, so it's really useful for me if I want to diagnose someone with the DVT. I cannot get straight away the ultrasound scans. If I would have this skill, I can quickly screen.
I think there was a lot of enthusiasm. I think people looked like they were interested in what we were doing, and there were a lot of questions which people were relating to their daily practice, which made me feel like it was something they thought they could take back into their workplace. It's a very steep learning curve when you're learning ultrasound, and it's something that's only really started to get well embedded in the last few years, and you need quite a lot of hands-on experience in the first instance to really understand what you're doing, where you're holding the probe, what you're actually seeing on the screens. This is designed as a very brief introduction to show people what can be done, and then there are training programs around so people can take it further and actually learn and get certified in ultrasound if that's something that they want to take forward.
Went through like what the different colours mean, air and more dense tissue, and you know, what the kind of things you want to be looking for, and landmarks as well, which is important to see where you are and what you're looking for.
Having done the lung station, it's slightly different to the sort of thoracic ultrasound training that I'd had, which was more about finding fluid and putting drains in, whereas from the acute medicine perspective, they'd focus a bit more on the lungs and are the lungs normal, which was quite interesting.
It was really a good initiative for me to get into that and go for the course and then follow that up.
This is just to refresh my memory, but for those who doesn't know ultrasound, I think it is definitely helpful.
Let's take a look now at the Future Hospitals COPD programme, where they're aiming to provide a consistently high quality of service for everyone across Manchester's 2 trusts.
About 18 months ago, a group of respiratory physicians and managers from the 2 big teaching hospitals in Manchester got together over dinner and had a conversation about how we could improve things for our patients. To give you some background, Manchester has Central Manchester Foundation Trust, which is situated in the middle of the city, and University Hospital of South Manchester, which is 7 miles further south. And there is a large population of patients, around 300,000, who live in between the 2 trusts. And historically, those services have been developed independently. They're commissioned separately by the Central and South CCGs. And access to those services, particularly in the community, are very much dependent on patient postcode and where they live. And this creates inequity in the system, and different patients may get different standards of care depending on where they live. Our overall mission with this project is to really understand what's important to patients and carers, and to bring services together regardless of whether it's primary, secondary, third sector organisations, to try and achieve those outcomes for patients. What this means practically on the ground is both vertical integration between secondary care and primary care, but also horizontal integration with Central Manchester Hospital Trust, and merging our frontline teams and ensuring we're working in the same way.
We've tried to integrate the teams across the 2 trusts by forming a series of joint meetings. These have progressed on to educational meetings, and then on to meetings that have looked at the operating procedures within the 2 trusts to try and standardise them. The teams have responded well to the integration because they've come with a very open approach to what they're doing. They form personal relationships across the 2 different trusts. Therefore, we've overcome the challenges that have been set up.
The Integrated Steering Group has developed a mission and vision and values document together, and we have clearly set out our objectives for the project. We're working on the principle of co-design, which involves bringing people together from different parts of the system, including patients and carers, and having those discussions about what do we do well, what could we do better, what does perfect look like. And having the richness of those perspectives has been really important and has directly influenced the services that we are now developing.
The project has tried to use the concept of co-design to look at pathways for patients. That is bringing all the stakeholders, as it were, together and asking for their contributions. I think that's worked quite well, I sometimes think, though, that role reversal might be considered. So if we looked at staff putting themselves into a position of being patients, what would they want, and patients putting themselves into the position of staff and understanding what they think might be a priority for the staff, might help us to move things forward.
The main benefit from the Future Hospital project for clinicians within primary care, I feel, has been the support that they give us. Over the years, respiratory care has been moved from secondary care into primary care, so we're now diagnosing and managing patients throughout the whole disease process. So as clinicians, we've had to become more skilled in being able to deliver this care. Through the Future Hospital projects, we've actually been given that support in order to provide that care. The Future Hospital project is different to previous projects. In previous projects, the design of the project has been made by senior managers, senior clinicians, and when it's been implemented, it's not always been fit for practice, and the support for clinicians hasn't already been in place. With the Future Hospital projects, because all the stakeholders get around a table at all stages of the development of the project, when it comes to be going live, then all the problems tend to have been ironed out, and the project can actually run and hopefully be very, very successful.
There's a number of major changes going on in Manchester at the moment. There's devolution, bringing more power to decision makers locally. There's the integration of services across the hospital sector and community services. And finally, there's the merger between University Hospital South Manchester and Central Manchester to create a new foundation trust for the city. I think the work we're involved here is absolutely vital. It's very much about looking at a different way of providing hospital services that's actually fit for the 21st century. And at the heart of it, I think, is about breaking down the sort of artificial barriers that sometimes have existed between hospital services and community services. And really on the basis of that, really sharing that learning with other partners across the NHS and beyond.
The future of the project is exciting. I think the work that's going on between Central and South Manchester is only the beginning, and there is a lot of opportunity to start working with our partners wider in the city, with North Manchester, Stockport, Trafford, to try and ensure that the respiratory care we're providing is not just high quality, but consistent and coordinated across the whole city.
With me now is Professor David Haslam, who is the chair of NICE. Welcome to you.
Hi.
Now, we're thinking about how to maintain quality in a stretched NHS. Now, what is your answer to that?
Well, everyone accepts the whole system is under enormous pressure at the moment. There's pressure on money, there's always going to be pressure on targets around waiting and so on, and there's pressure on quality. And one of the things I feel really strongly about is that we mustn't dumb down quality. If anything's going to slip, it mustn't be quality. Two reasons, really. One is, would you feel happy going to see a doctor who aspired to mediocrity? Of course not. Not for yourself, not for your family. So no, there's an ethical responsibility to do this. But I also feel that if we do dumb down quality, there's a real risk that the public will begin to lose faith with the health service. And that, to me, is really important.
You do have this quote, it's not new, that there's three things you want to achieve and you can only really have two.
Yeah, you can choose two of quality, affordability and access, by which I mean sort of waiting time. So for instance, in general practice, everybody in Britain could see their GP tomorrow if they had a 1-minute appointment. So it'd be affordable and it'd be good access, but it'd be completely hopeless quality. Or you could have really high quality doctors able to see you tomorrow, but we wouldn't be able to afford it because you'd need so many more doctors. So you have to find ways through this real dilemma. And my passion is that we must not dumb down quality. Therefore, we have to do things differently. We have to look at things we're currently doing that we could do in a different way.
And you also have this thing, don't do things that don't need doing. Like what?
Absolutely, absolutely. The Academy of Medical Royal Colleges, which of course the Royal College of Physicians is an important part of, has developed this thing called Choosing Wisely. In Wales there's an initiative called Prudent Medicine. In Scotland they've got a thing they're calling Realistic Medicine. And this is really looking at everything you do. Does it really need doing? Are you doing the right thing for the patient? Coming from NICE, I'm passionate about guidelines. There's good evidence that if you follow guidelines, you'll get better results at lower cost, but at the same time we must make sure that we focus on the individual patient.
And one of the things that really worries me is when people unthinkingly follow guidance and add more and more and more drugs.
Yeah, the over-prescribing, isn't it?
Over-prescribing. So the average person in a care home is on 9 different medications. Is that wise? What do we know about the interactions? What are the risks from that? So there's so many things we could do that could reduce the amount of activity to everybody's benefit. I'm not just trying to save money, I'm trying to improve quality.
Now, you've got to add into that people's expectations. You know, they come in like, I want to come away from here with some drugs, I want a prescription.
Well, yes and no. I mean, one of the really interesting things, and particularly in surgery, is that the more information you share with the patient about what the real outcomes are likely to be, then actually the less medicine they choose. It's very interesting with doctors themselves. Given an opportunity to have treatment, doctors tend to choose somewhat less than their patients, which has always fascinated me. NICE has developed a number of things around shared decision making. How do we work with patients so they really understand the risks and benefits of a particular line of treatment? And of course every doctor knows lots of patients who collect prescriptions and then don't take them, and bathroom cabinets are full of untaken pills. That's waste. That's, you know, so if we really tackle that sort of thing at the start rather than waiting to the end, then there's real benefit.
And how much progress do you think we're making on this journey?
Oh, I think we're beginning to. I think more and more people are understanding. I find a lot of doctors, when they look at their own families, maybe their own elderly parents, and see them on too much medication, too much of their life taken up with seeing doctors and going to appointments and so on. We need to step back and say, what are we trying to achieve? What's the real benefit for the human in front of us?
Well, on that note, Professor David Haslam, thank you very much.
Thank you.
Now I've decided to leave the studio and head out to find out what you think. First, I'd like to know, how can physicians and the RCP improve the patient experience?
To improve the patient experience, it's very difficult with the resources we have at the moment.
Many doctors feel frustrated that they're being pressurised to see too many patients in too little time, and that degrades the service.
The balance between the time that you have and the quality of the consultation, and I think the key thing is about communicating well with patients.
Maybe sometimes having patients actually in these kind of talks, patient groups, layman, let us see their views as well, because I think it's ever challenging. We know that patients' experience or expectations are ever increasing.
We're not really doing very well in terms of reflecting the patient satisfaction, patient views to the work stuff. So this would be one of the areas I would like to incorporate into my own practice as well.
I work in a district general hospital, and as every hospital across the country, we are really under immense pressures. The acute takes are getting busier and busier, and especially the patient's experience is unfortunately sometimes lost in the big picture.
Now let's head over to University Hospitals Coventry and Warwickshire NHS Trust, where their respiratory department has grown into a world-class facility.
The respiratory department is one of the key medical departments in the hospital. It provides non-elective medical care for general medical patients and highly specialised respiratory services. The respiratory department has trebled in size. With this expansion has come the opportunity for us to develop highly specialised tertiary services, and we've had to evolve using innovative and creative methods. A good example of this is how we've delivered our COPD services.
COPD has been transformed in Coventry over the past 10 years. Locally, one of our challenges is around the population that we serve. Coventry is a marmot city, which means there's high levels of socio-economic deprivation, there's a high prevalence of smoking and lung disease. We strive to be innovative and creative in our approach. An example of this is our Ripple project. What we've tried to do here is move away from the traditional medical model of COPD care and treat patients more holistically. Coming to St Peter's Centre here once a week offers our patients the opportunity to increase their social networks.
Without Ripple, we wouldn't be able to come down, meet friends, have some fun,
and get introduced to other people, and all we'd be doing is staying at home doing nothing. I would like to see Ripple introduced all over the country because it's such a good thing.
Our key performance indicators were primarily to reduce hospital admissions. Our improvements can be demonstrated through Dr. Foster data, in that we're one of the best performing COPD services in the West Midlands, as we've reduced admissions to hospital by 12%.
Our Complex Airways Disease Clinic is a multi-professional clinic that focuses on the care of patients with complex COPD and overlap syndromes, as well as genetic COPD. Alpha-1 antitrypsin deficiency is a complex multi-system disorder, and the service is delivered by a team of consultants from various specialties, including hepatology, dermatology and respiratory medicine. Another example of our innovative ways of working is the way that we deliver our sleep and ventilation service.
Incidence and prevalence of obstructive sleep apnea is ever increasing. We have developed a fast-track service here at UHCW, which caters for the need for the professionals, including AGV drivers, so that they get seen, investigated and treated within 5 working days of being referred. One of the new service development changes that we have implemented is to take our sleep service to our local prison twice a year, which means the inmates who are our current patients get the service within the prisons without the need for them to travel to the hospital. Technology is getting better by the day, which means that we can remotely monitor and adjust the therapy of our patients that are on home non-invasive ventilators. That reduces the number of visits that they have to come to the hospital for, and our team can also support them at home.
In parallel with this increase in workload and clinical complexity has been the need to develop our diagnostic services. Our respiratory physiology department provides high-quality service that underpins our clinical provision and our research.
Respiratory physiology investigations are vital in the treatment of patients with lung disease. We can follow up patients long term who are on treatment for their condition. We can monitor their progression of their disease. Since the department moved to the new building in 2006, we've expanded dramatically. We've gone from 5 members of staff up to 22. We've developed specialist exercise testing services. Our vascular preoperative testing service has been instrumental in reducing mortality from 12.7% down to 2%, and also reducing length of stay by up to 3 days. We're continuously striving to improve standards within the service, and this was evidenced by our recent successful accreditation with IQIPS. To date, we are the only accredited service in respiratory and sleep in the United Kingdom.
Research is vital in transforming clinical services and improving patient outcomes. Consequently, we've endeavoured to integrate clinical research into our clinical services. My research interest is in the use of imaging to measure lung disease. For example, CT can be used as a densitometer, and diseases like emphysema result in change in lung density so that CT can be used to monitor disease progression over time. This allows it to be used as an outcome measure in drug trials as well as to accurately phenotype patients. CT also provides excellent morphological detail, and so it can be also used to measure textural changes in the lung, such as occurs in interstitial lung disease. In conjunction with Professor Abir Bolero at the Warwick University, we've developed a software program that allows us to do this. These research techniques lend themselves to use in routine clinical practice, but they first need to be standardized. We've developed a phantom that has allowed us to reduce the variability in CT densitometry measurements across different sites by 85%. The respiratory department has expanded greatly over the last 10 years, and we've used innovative and creative methods to develop highly specialized, high-quality services. I anticipate that we will continue to expand and that we will be able to meet the challenges of healthcare in the future using our same innovative and creative methods.
Over to Health Education England, east of England now, where the School of Medicine is training exceptional doctors.
The Postgraduate School of Medicine in the east of England is responsible for training junior doctors in the physicianly specialties. So we have about 250 core medical trainees and currently about 450 higher specialty trainees, but that number is set to increase in the near future. Health Education East of England covers the areas from Hertfordshire and Essex in the south, stretching up through Bedfordshire and Cambridgeshire to Norfolk and Suffolk in the northeast. Within that area we have two large cities in Cambridge and Norwich, both of which have world-class universities.
At Health Education East of England, we're trying to train consultants and GPs who are going to be the best that we can possibly make them, and are going to work within the East of England and really make a contribution to patient care.
I trained at Norwich Medical School and I loved it so much that I've not been able to leave Norfolk. So I did my foundation year training in, first of all, Great Yarmouth, the James Paget Hospital, and then the Norfolk and Norwich Hospital. And then I've stayed in Norwich for my core medical training. I hope to follow a career in cardiology, and the departments in Norwich have been beyond supportive, both helping me in research and also to get some hands-on training in the cath lab.
I trained in Oxford and I've always been very interested in gastroenterology and epidemiology. And I'd heard of a very famous epidemiological project that takes place in Norfolk, the European Prospective Investigation into Cancer, which was what prompted me to apply for an academic foundation programme in Norwich. Since then I've been working with him as my supervisor, and it's gone very well, and I've had the opportunity to present my work at important meetings such as the British Society of Gastroenterology.
After core medical training, which is a period of 2 years, they have the opportunity to then apply to a higher specialty. These include things like cardiology, respiratory medicine, gastroenterology, endocrinology and diabetes, geriatrics, as well as a lot of smaller specialties like clinical pharmacology, allergy, immunology and genetics.
I'm training in respiratory and general internal medicine in the East of England region, and I chose this region because of the breadth and wealth of opportunities available both in clinical and academic medicine, which takes place at some DGHs but also the tertiary centres, and in particular Papworth Hospital, which is an international centre of excellence for many different respiratory subspecialties.
One of the things that we're particularly good at in the East of England is simulation training. All of our core medical trainees get the opportunity of at least 1 day of practical skills training and a second day of working in acute medical scenarios. We run the largest programme for simulated acting up as a medical registrar, and most recently we've trialled the use of cadaveric material when trainees are practising practical procedures. One of the most exciting things that's happening at the moment is what we've called the repatriation project. So there are a number of posts, particularly in Hertfordshire, Bedfordshire and Essex, which are currently filled by trainees from London programmes. We're going to take those posts back into the East of England programmes.
The repatriation project over the last couple of years has led to the need to rebalance our programmes, and how we've managed to incorporate this is by creating more training posts in tertiary referral hospitals. So there's been quite a number of new posts in Norwich and Addenbrooke's, for example, and what that's led to is a much better kind of trainee experience and higher training in particular.
The jewel in the crown of the East of England is the biomedical campus around Addenbrooke's Hospital, and trainees that come to this region will have the benefit of working in a world-class institution.
The Cambridge Biomedical Campus is something that we try and give exposure to most of our trainees. It is the world-leading centre for genomics and for gene therapy, cell biology, and to see that translated into real-life clinical care is extraordinary.
As an academic clinical fellow in medicine, the East of England is a fantastically exciting place to be, with the expansion of the biomedical campus on Addenbrooke site. With it's brought lots of fantastic facilities, and I've really felt the benefits of the close links and networks between different labs, institutes and industry itself. So I do feel very privileged to be here.
We like to give our trainees in East of England other opportunities. It's not just about academic training and clinical training. We give people opportunities in leadership training, working with the Judge Business School as part of Cambridge University. We're part of the clinical entrepreneur programme, allowing people to take a flexible approach to develop new technologies and new commercial interests alongside their medical training. We're very keen on allowing trainees to develop experience in education. We support them to do certificates in medical education and up to master's level study. We want to train leaders and educators of the future. My personal passion as Dean is around global health, and I love to give up trainees opportunities to work in developing countries. We've got well-established schemes in sub-Saharan Africa, in KwaZulu-Natal and the Eastern Cape, allowing people to make a real contribution to third world healthcare. Trainees come back from global health placements with a huge amount of clinical knowledge, but alongside that, leadership, self-resilience, transformational sort of skills, which we exploit shamelessly and bring into the NHS. They're the people who are going to be the leaders of the future.
The East of England is already a great place to live and work, and we genuinely believe that it's going to get even better over the next few years. So if you're looking for somewhere exciting and supportive to come and train, we'd be delighted if you would join us.
Well, with me now are two members of the RCP Trainee Committee. We have the Chair, Carol Postlethwaite, and also Orod Osanlou, who is the Deputy Chair. Welcome to you.
Thank you very much.
So basically, what are the major challenges, would you say, facing trainees at the moment?
The healthcare environment at the moment within the UK is under great stress. With the great stress becomes a difficulty with balancing the needs of trainee doctors to receive training with the undoubted increase in the need to deliver a good, safe service to the patients that they serve. The problem that we're having at the moment is, in particular, everybody's been aware of the increase in workload over this Christmas, which has been one of the busiest winters that we can remember. More hospitals than ever have put out Opal Style 4 alerts to signify that they're under incredible pressure and at breaking point almost.
And Orod, what do you say, things are getting better or worse at the moment?
Most people think that things are getting worse, and if you speak to senior physicians who have been consultants for 30 years, they're saying that what we're experiencing now is unprecedented and arguably the worst that they've experienced. And then you get a generation of junior doctors and people who are aspiring to be junior doctors who are seeing this happen. And we've had applications to medical school for issues with people progressing through training, and we need to be appealing to those junior doctors and making people realise that medicine is brilliant, so that we can try and help patients as much as we can.
And one body that's helping, of course, is the Trainee Committee. So what sort of work are you doing to help?
When I was going through my training, I didn't really know about the Trainees Committee at all. It was I got approached by a consultant when I started my first registrar job, and he happened to have been the outgoing chair of the Trainees Committee and said, had I ever thought about working for them? And I'd never heard of them. That, I think, is one of our biggest problems, is because the vast majority of the trainees who work within medicine probably don't realise that there are a group of elected trainees, elected by them actually, who sit on council and within the Royal College and represent them in terms of reminding the college that actually its very function is to have very high quality training for them and to be the voice of them in the future. We are, after all, the future of the college.
And Orod, would you say that the committee has had any particular success with initiatives or things that you're pushing through?
Yeah, we engage with doctors a lot more, with junior doctors a lot more than the Royal College has traditionally in the past. The website has been updated. We send out more correspondence to our members as well. And we've also been involved on a trainee level with various communications, for example, a letter that was signed by all of us, but including President Jane Dacre to the Prime Minister, outlining some of these issues.
We're also the voice of the trainees for issues such as the very well publicised problems around the trainees' new contracts last year. And I personally wrote a letter to Jeremy Hunt explaining the frustration. We liaise within the Trainees Committee with a lot of other organisations as well across the healthcare environment. For instance, the Academy of Royal Colleges, there's a Trainees Doctors group on that, and all of the Royal Colleges have doctors, and we formulate strategy to make sure that the voice of the trainee is very much fore and central most.
And what would you say is your biggest headache, and how do you think the RCP is supporting you through that?
There's an issue surrounding work-life balance, which is a big problem. There's been a few unfortunate cases recently of doctors who have suffered ill health and worse. It's a reminder of that doctors are human beings as well, and everybody needs support at times. So the Royal College have released various public documents which have a scientific backing to them, which tries to support junior doctors. So, for example, Keeping Medicine Brilliant underfunded, underdoctored, overstretched. And another one which is in development at the moment about medical registrars and quality criteria, which will help both with training and also the holistic overview.
So what do you think that trainees particularly get out of RCP conferences like this one?
Well, there's lots of different reasons to come to a conference such as this. There's a poster opportunity, so junior doctors come and bring their posters. There's a networking opportunity, so there's I think about 800 people here today, so there's a big opportunity to meet your peers. And there's also a big learning opportunity as well. So there's cutting edge things that we've spoken about today that I'm very excited to go and see.
I think it's a fantastic opportunity to find out about what innovations are going on in other hospitals and take them back to your own organisation and improve patient care and your own sort of services as a result. And we get a lot out of conferences. One of the big initiatives that we're trying to do at the moment is we're setting up a trainees conference, which we're hoping is going to be at the very least very cheap, or we're hoping free to all members of the Royal College who are trainees. And that's going to happen sort of May, June next year in Birmingham. So watch this space, it's going to be fantastic.
And it's going to coincide with the 500th anniversary of the Royal College as well.
There you go. All right, well, both of you, thank you very much.
Thank you.
Very much.
Physician associates are playing an increasingly important role in the NHS, and the RCP is keen to recognise and support this. Well, we got a chance to speak to a few of them about the role that they play.
A physician associate is a new healthcare professional who's trained specifically to work in medicine to deliver medical care to patients, and that means working in conjunction with the doctors to do that. So we have PAs who are working in paediatrics, we've got PAs working in general medicine, in surgical specialties, so across the full range.
I became a physician associate because I was really looking for a challenge in my career. I couldn't see doing the administrative roles that I had been doing for another 30 to 40 years until the retirement age. And so I looked around and I had become interested in medicine and taking care of patients. And so I thought many years of becoming a doctor, or actually a fairly short course, very, very intensive, to become a physician associate, and my decision was made, and it's the best decision I ever made.
I became a physician associate because my previous job working in a lab was quite insular. I wanted to have a much more patient-facing role, and I heard about physician associate studies and I decided that was what I wanted to do. I think certainly within a hospital a physician associate adds a huge amount to a medical team, because rather than say an SHO or registrar who rotates on their placements, a physician associate will stay on the same ward within the same team for potentially their entire career, but certainly longer than 6 months or 9 months. So it gives that level of continuity.
So my current role is as the course director for Physician Associate Studies at St. George's, University of London. So our program is in its 9th year. We started with very small numbers, but now we have a fairly large group of students in our first year, 68, and we are contributing every day to the medical workforce. Our second year students in particular actually provide a service. So yes, they are students, but they are seeing patients and delivering part of the service even as students.
We're all postgraduates. We've all done biomedicine or nursing, or in my case genetics. We have a good fundamental understanding of how the human body works before we even start training. And then it's a 2-year incredibly intensive, incredibly rigorous training program that we go through.
I believe that physician associates really add benefit to the medical teams. They are a consistent member of the team. They increase access to healthcare for patients. They increase training opportunities for the junior doctors. We know there is a huge crisis and pressure in the health service right now in terms of the workforce, and we know that actually having a physician associate will actually help distribute the workload and therefore improve hopefully the work-life balance and the quality for all of the multidisciplinary team, including the doctors, because they can share that workload.
So the role of the physician associate in the NHS is actually unlimited, in my opinion. So we can expand into any areas. There are already physician associates working in research, we work in education, we are involved as experienced physician associates in the education of medical students and junior doctors. Obviously a newly qualified physician associate isn't teaching a foundation year 1 doctor, but it is as we expand our role we can make that contribution as well. freeing up the consultant's time or the registrar's time as well to do the things they need to do.
We are at the point where our numbers are rapidly increasing, and people are coming into the workplace, and obviously the workforce crisis and that's ensuing at the moment within medicine. PAs are there to help ease that workload and ease that pressure.
Let's go to Papworth Hospital now, where they're providing innovative solutions to support cardiac patients.
Papworth Hospital is a regional cardiothoracic centre based just outside Cambridge, serving the population of the east of England, which is approximately 2.5 million people. Our cardiology department currently provides both invasive and non-invasive services for our referring hospitals across the east of England. Invasive cardiology services includes the catheter intervention for patients with coronary artery disease, or catheter ablation for cardiac arrhythmias, or for patients who have structural cardiac problems. Our non-invasive services cover the whole spectrum of cardiac imaging, such as echocardiography, CT scan, and cardiac MRI scan, for example.
Papworth Hospital will be moving in April 2018. We will be next door to Cambridge University Hospital's Addenbrooke's. We'll be adjacent to many university buildings and many research facilities and pharma buildings. The facilities for cardiology in New Papworth are fabulous. 5 dedicated cath labs with a hybrid lab which is new. There will be purpose-built day ward facilities, single bedrooms to care for our inpatients, and dedicated facilities for cardiology patients within the outpatient arena. Working with other hospitals, with primary care, with GPs, with local government is what's key to making any pathway work better for the future. We don't have all the answers, but we're working closely with our colleagues across Cambridgeshire and Peterborough, particularly on the elective care cardiology pathway to improve that experience for patients.
Patient pathway starts in the local hospital, who refers the patient to the National Pulmonary Hypertension Centre. Chronic thromboembolic pulmonary hypertension is a very distinctive form of pulmonary hypertension with a mechanical obstruction caused by the pulmonary embolism in the pulmonary artery. The most important and treatment of choice is surgery with a pulmonary endarterectomy, and now we are having this new mean of the management with the procedure called pulmonary balloon angioplasty.
Balloon pulmonary angioplasty is a keyhole surgical technique where we gain access in the patient's groin through a vein and thread catheters up into the lung vessels, and then we use wires and balloons to dilate webs that are causing chronic thromboembolic pulmonary hypertension. By inflating these balloons through these narrowings, which we call webs, we divide these adhesions and improve blood flow to the lung tissue, thereby improving the patient's symptoms and their hemodynamics. Balloon pulmonary angioplasty shares many similarities with coronary angioplasty. Some key differences are that the vessels are a lot larger and they are moving with the patient's respiration, so we have to ask the patients to stop breathing in order to perform the procedure. The new Papworth Hospital will have bespoke imaging facilities which will include a larger imaging plate which will enable us to capture the entire lung field in a single shot, and this will make taking imaging of the pulmonary arteries much more efficient.
The role of balloon pulmonary angioplasty, or BPA, in chronic thromboembolic pulmonary hypertension is still yet to be fully defined. The definitive treatment for chronic thromboembolic pulmonary hypertension, or CTEPH for short, is still pulmonary endarterectomy surgery. This is a very well recognized treatment for CTEPH. It is in some cases a cure for patients with CTEPH, and is a very well established operation, especially in a high volume center. In the United Kingdom, the only sole center for this service is done here at Papworth, and we are one of the highest volume centers in the world. However, of all the patients diagnosed with CTEPH, we think that only 60 to 70% of patients are suitable for surgery. Therefore, there is about 30 to 40% of patients, which probably accounts to about 60 to 70 patients a year, that would miss out on surgery and would have a much poorer outcome as a result, and simply be confined to tablets.
The future for the cardiac department of Papworth Hospital is very exciting. In spring 2018, we will be moving to a brand new hospital on the Cambridge Biomedical campus, co-located to a world-renowned university hospital. Once we're over there, we will be able to take full advantage of the close links with the university hospital in terms of research, education, and delivering excellent quality of care to our patients.
Well, let's head out now to talk to you guys again, and I'm asking, what have you learned from the conference that will improve your practice?
The main focus now seems to be on quality improvement, trying to incorporate that into our daily practice and try and change the culture of the NHS into driving more quality improvement, which will lead to good patient quality care as well as cost improvement and meeting the financial constraints and burdens that we've got these days.
Maintaining quality in a pressured system, I think that's very relevant at the moment, and there was lots of talk about clinical leadership and teamwork and things like that.
I mean, from the clinical side, we learn new things, how to diagnose and how to transfer the information to the patients.
It's always very useful to go and have a look at your specialty and hear from your colleagues. And as a consultant, it's always very reassuring to know that I've got it more or less right.
I think by prioritising the leadership and giving roles to people who are involved in the NHS would improve the service.
The government should listen to the ideas of doctors about how the NHS can work.
Let's go now to Royal Blackburn Hospital East Lancashire NHS Trust, where improved services have had a major impact on cardiovascular morbidity and mortality.
The East Lancashire NHS Trust serves a population of 530,000 people. In the last 10 years, we've made a big impact in cardiovascular mortality and morbidity within this area. The 30-day post-MI mortality was achieved very quickly within the first 12 months of the new services. This was mainly down to a 24/7 cardiology-led coronary care unit and people getting their appropriate medications and interventions in a timely manner. The impact of the last 10 years has been down to a number of developments. This includes a 24/7 on-call service by a cardiologist, a 24/7 coronary care unit led by cardiologists, development of a percutaneous intervention service, development of pacing services, and of imaging services.
We carry out a lot of different types of research here in the cardiology departments, both general cardiology, looking at patients with cardiac arrhythmias, patients with heart failure, different ways in which these patients can be managed. My personal interest and that of the majority of my colleagues is in interventional cardiology.
Development of on-site interventional services in East Lancs began in 2010. It was an area that's previously been quite neglected, and it's allowed us to transform the patient's care. Cutting-edge procedures we do currently would include high-risk procedures such as rotablation. We also do complex CTO procedures, which are chronic total occlusion procedures.
Approximately 4 years ago, we were invited to participate in a multi-centre novel study looking at different pharmacological treatments for patients receiving coronary stents. We were required to recruit 100 patients, and we eventually recruited 250 patients in 2 years. We were the first UK centre to start recruitment, which has encouraged people to come back to us and test other stents. The department is keen on publishing and research, and we've published 2 main papers over the last few years. The first showed how outcomes could be improved through the reconfiguration of services within a trust. The second showed how outcomes in patients receiving angioplasty in sites without an on-site surgeon are comparable to those receiving care in a tertiary centre.
The new cardiology service started about 10 years ago with the appointment of 3 new consultants,
and one of the focus was to develop the pacing service. We implant single-chamber pacemakers, dual-chamber pacemakers, and more complex devices called biventricular pacemakers, which is also called cardiac resynchronization therapy. This sort of device, which is a complex procedure, is implanted in patients with advanced heart failure in whom medical therapy proves insufficient. It involves implantation of 3 leads into the heart, 1 into the right atrium, the second into the right ventricle, and third, which is the most important, to pace the left side of the heart by passing a lead into the coronary sinus. We have done about 175 of these procedures in the last 3 to 4 years and had excellent outcomes.
I had my biventricular pacemaker fitted. It was June last year. It's worked so well for me. I found I can move about a lot more, I'm not tired, I'm not short of breath, I can walk for a long time, exercise is brilliant as well. I have a home monitoring which is all through the Wi-Fi, and basically I don't need to come to clinic, it's all done at home. The girls here, they just download everything. At Royal Blackburn Hospital here, the service has been so wonderful, they've taken so much care of me, they've looked after me from the start to the finish.
One of our major future plans is to develop a local ICD service, which essentially is implantation of internal defibrillators. The procedure itself is exactly the same as implanting a pacemaker, but the device itself has the added benefit of detecting and treating dangerous, potentially life-threatening changes in the heart rhythm.
So there's a wide variety of outpatient services that we offer here at the East Lancs NHS Trust. We're able to offer some advanced non-invasive cardiac imaging services as well. So we perform cardiac CT here and cardiac MRI, and being one of the few, if not the only district general within this sort of Greater Manchester or Lancashire region to be able to perform cardiac MRI scans. So we have a 1.5 Tesla MRI scanner used for all purposes, but we perform 4 to 5 cardiac scans on that MR scanner per week, and we're able to readily identify those people with structural heart defects or those people with bad heart failure, which helps risk stratify their management when we see them in the clinics. We perform around 2,000 treadmill tests per year here. We're able to perform treadmill tests here and cheaply and correctly identify those patients that require further investigation and those that do not. We perform around 300 to 400 dobutamine stress echocardiograms per year here at the East Lancs NHS Trust, which very much follows the guidance set by the National Institute of Clinical Excellence, and we generally reserve that test for those patients we feel are in the moderate or high risk categories of chest pains.
I had a heart attack on the 9th of December, brought into hospital by the ambulance, had 8 heart attacks in a very short period. I had 50 then over a 2-week period. The staff at Blackburn CCU were absolutely fantastic. They saved my life. They all worked very, very hard over a few weeks, basically 4. They stood by me, they stood by my family. They fed them information where they needed to, but more importantly, they kept me alive.
The cardiology services at East Lancashire Hospital is a modern comprehensive department. We provide a very busy outpatient service. The inpatient work comprises of a 24/7 on-call commitment by the cardiologist. We have invasive services with percutaneous interventions to coronary arteries and the implantation of pacemakers. We also have a full array of imaging technologies including echocardiography, CT angiography and cardiac MRI.
With me now is Suzie Bailey, who is Director of Leadership and Quality Improvement at NHS Improvement. Hello to you.
Hello.
Now, what's the main focus of what you're saying at the conference?
Okay, my main focus is around the importance of leadership and developing good teamwork, and that's where the patient is part of the team.
Now, you'd think that sounds like motherhood and apple pie, that everyone would be doing that anyway.
You would, but actually the art of real teamwork does need practicing. It's about the opportunity for a team to reflect, it's about having good data, and it's about being really clear about the objectives that a team is working on. And sometimes that can get lost in the myriad of things that teams are trying to deliver in healthcare.
So how good do you think we are at leadership and in the NHS?
I think we've got some fantastic examples of leadership in the NHS, and I think when we talk about leadership in the NHS, we need to understand that leadership happens at all levels. Often the focus can be on the most senior level, so the chief executive level, and that's an important role, but actually leadership needs to happen at every part, and that's what we call collective leadership. So that's how we distribute leadership, so that every member of staff understands the responsibility they have.
And how do we get to that point?
So how we get to that point is having very open discussions with teams and actually discussing roles and what's important in the team, so what we need to achieve, being really clear about objectives, and also making sure that staff are supported in their role. So do they have the right training, do they have the right equipment, do they have the right supervision? So if they're on a shift, are we actually taking care of them as an individual working as part of that team?
And what's your biggest challenge in achieving that?
So I think the biggest challenge is the, I suppose, the pressure on the system at the moment. So the thing that we're talking about today at the conference is how to maintain quality in a pressurised system. The NHS is a very busy system, there's very competing demands, we've obviously got an ageing population, there's lots of reasons why there's pressure on the system. So I think the biggest challenge is helping people to understand the role they have in leadership and understand that leadership isn't something that happens elsewhere, it's not something that somebody else does, that actually as a member of a team you have an important role in leading that team too.
And that's quite a culture change, is it? Quite a shift in, and how do you achieve that, do you think?
It is. I mean, understandably, the NHS has had a culture that perhaps has been a bit more command and control, and there is a place in situations where, you know, direction obviously is important, but actually changing the culture and actually helping people to understand what creates the right environment for staff to do their best work is really important. So actually getting staff talking about the culture that they're creating, what's the environment like, and involving patients in that conversation, because patients are really experiencing that at first hand, so they're an important member of the team too.
Do you think that there is the time to do this extra training, have these extra conversations? I mean, it all sounds great, but aren't people just drowning under the weight of work that they're doing?
I genuinely believe we do have the time to do it, because I don't believe this takes a lot of extra time. I think it is about the day-to-day behaviours that we practice. It was interesting, as I came into the conference today, I was talking to the woman in the cloakroom about what I was going to be talking about, and she said, well, it's about people and behaviour at the end of the day, isn't it? And I said, yeah, it is. It's about the relationships that we have every day. So in every shift, you know, how am I working with you? How are you working with me? How are we understanding the work we've got to do? So I think that's the art of the work. So I don't think it takes extra time.
All right, well, Susie, good luck with that. Thank you very much.
Thank you very much.
Well, that's the end of our coverage of the conference here in Manchester. We hope you've enjoyed our coverage. Remember, if you missed anything, want to watch again or share clips with colleagues, the show's available at the conference centre and at the Hilton Deansgate until the end of the conference, and everything will be available online well beyond the conference. Look out too for any extra content that didn't make it into the show, which will be available in the near future. We've enjoyed it very much here at Medicine 2017, and we hope you enjoyed our show.